Eva. Good evening, everybody. We start immediately this session. I am Professor Youssef Ben Amr from Tunisia. I would like to thank the organizing committee for this invitation. It's my pleasure to moderate this session with my friend Salah Al-Badri from Qatar. This session is a joint session between Libyan Cardiology Society and Pan-Arab Association of Heart Failure. So without delay, we will start with Dr. Hadi Skouri to present a challenge case about chemotherapy-induced cardiomyopathy. It will be his second conference.
Good evening. Thank you, Dr. Youssef, for the kind introduction. So, are you hearing me? Can I continue? Hello? Are you hearing me?
Yes, we can hear you.
Okay. So, this is my disclosure. And basically, I will talk about a case of cardio-oncology presenting with chemotherapy-related cardiac dysfunction. This is my topic. Before I start presenting the case, I would like to start with what is cardio-oncology, which is a new era in cardiology. And actually, it's a subspecialty by itself. But because we have advancement in chemotherapy over the last, and targeted therapy and immunotherapy over the last 20 years, and this has improved survival of cancer therapy. But this chemotherapy and targeted therapy and other immunotherapy, though they improve survival and cure patients from cancer, and at the same time they have some side effects or cardiotoxicity. And we can see that this cardiotoxicity is not only cardiomyopathy as we used to know before from radiation therapy to the chest and from anthracycline-based therapy, but there are other cardiovascular toxicity that include hypertension, vascular disease, pericardial disease, myocarditis, arrhythmia, as well as valvular heart disease. Basically, cardiomyopathy, hypertension, and vascular disease are the most common in these patients. So the second thing that I want to highlight on is that the patients with cancer, actually their survival rate has been increasing, and not only the survival rate, but the diagnosis is being, these patients are being diagnosed at a late age, which means that above 60 years of age, and some they are diagnosed even at 85 years of age and up. And these patients already have some baseline cardiovascular complications like hypertensive coronary disease, etc. Not only that, but if you can see on the right side that patient living post-cancer diagnosis, 20 or 15 years has been increasing too. So we are witnessing a higher rate of survival. And by that, the more the patients are surviving, the more they may develop cardiovascular toxicities, and the more they develop cardiovascular disease due to their aging also, and to their different comorbidities. So it's not only cardiac dysfunction or heart failure, but myocarditis is another entity, especially with immunotherapy, vascular toxicity, especially with tyrosine kinase inhibitor and vascular endothelial growth factors, hypertension also with tyrosine kinase inhibitors mainly, as well arrhythmias and QTC prolongation that will lead to arrhythmias and sudden cardiac death. So the aim of treatment or monitoring in these patients who are being administered potential cardiovascular toxic drugs to see what is the lowest possible cardiovascular risk and to balance it with the best effective cancer therapy. And from here, the cardio-oncology has, as a subspecialty has been evolved. And the major 4 or 5 elements of cardio-oncology is risk stratification, early diagnosis, prevention, treatment, as well as I added long-term surveillance. Because we don't want the cured cancer patient of today to be the cardiac patient of tomorrow. And the main goals of the cardio-oncology service is to avoid the possibility that cancer therapy could induce cardiac disease, to avoid cardiotoxicity from interrupting cancer therapy. We should not interrupt cancer and decrease survival just because of the cardiotoxicity. Also, to avoid the possibility that pre-existent cardiac disease be a barrier to start a therapeutic cancer therapy that may improve the survival, as well as follow-up patient at risk of cardiotoxicity post-cancer therapy is important, especially in anthracycline and radiation-based therapy where we have late cardiovascular complications. As you can see from this slide, there are multiple classes of drugs that can cause heart failure or cardiac dysfunction, not only anthracycline chemotherapy, HER2-targeted therapy, vascular endothelial growth factors, multi-targeted kinase inhibitors, proteasome inhibitors that are being given to patients with multiple myeloma, especially carfilzomib, can increase the risk of heart failure, and others can, like immune checkpoint inhibitors, can cause cardiovascular dysfunction, whether directly or indirectly through myocarditis. So we have different mechanisms of heart failure from oncology drugs, either direct cardiotoxicity, like direct myocardial damage, like the prototype of anthracycline, or indirect cardiotoxicity from myocarditis, like immunotherapy, ischemia, arrhythmia, or valvular disease from radiation therapy, or development of other systemic hypertension or pulmonary hypertension, like in tyrosine kinase inhibitors, that will lead to, in the future, for cardiac dysfunction and heart failure. So we consider cancer therapy, whether radiation or chemotherapy, as risk or as novel cardiovascular risk factors, and patients in stage A or stage B in heart failure stages, where they are at increased risk to develop heart failure, if they are given these potential cardiotoxic mechanisms, then they are considered as risk factors to develop heart failure, as others like obesity, hypertension, diabetes, coronary disease. Also, using cardiotoxins is important in these patients. The first European Society of Guidelines or Cardio-Oncology Guidelines was published in 2022, and in this guidelines there were new definitions of cardiotoxicity. So when we come to chemotherapy-related cardiac dysfunction, we have to divide them whether symptomatic heart failure or asymptomatic cardiac dysfunction. In asymptomatic, which are important as asymptomatic, either we have a drop in ejection fraction to lower than 40%, and the patient is asymptomatic, this is severe. Moderate, if there is a drop between 40 to 49% EF, this is moderate. And mild, if the EF stays above 50%, but there is a drop in global longitudinal strain by 15% or more, or rising of biomarkers, which can signify early cardiovascular or cardiac toxicity that may lead with time, and from previous old trials have shown that if they have persistent elevated troponin or reduction in GLS, these patients are at a higher risk to develop heart failure or chemotherapy-related cardiac dysfunction. So we start with a case, 36-year-old lady referred to my cardio-oncology clinic after she has been admitted with acute de novo heart failure a couple of months ago. She is not known to have any cardiac risk factors, but going back to her oncology history, she was diagnosed with high-risk acute myelocytic leukemia, treated with induction and consolidation therapy that include anthracycline in these patients. And actually, the total anthracycline doxorubicin dose that was given to her is equivalent to 127 milligram per meter square. Why it's important to know the cumulative dose? Because we know that anthracycline cardiotoxicity is related to the cumulative dose, and usually above 250 milligram per meter square of doxorubicin or equivalent should be considered a high risk for these patients. And always, when patients are on any of these anthracycline-based therapy, we should know the total equivalence of anthracycline in these patients. And as you can see from this curve, that there is an exponential increased risk of heart failure with the higher dose of doxorubicin, cumulative dose. But this cumulative dose, usually we can start having the increase of cardiotoxicity at 250 milligram, but this doesn't mean that less than 250 milligram per meter square they don't develop cardiotoxicity. It depends on genetic predisposition, aging, other cardiovascular risk factors, if they have radiation therapy before, or other concomitant cardiotoxic therapies. This is why 250 is the cutoff points sometimes for high risk development, but this doesn't mean all the time that lower than 250 they don't develop. So this patient following up, because we need to take a good oncological history. She has done donor allogenic bone marrow transplant, and usually in these bone marrow transplant they give conditioning therapy with also chemotherapy. In her case, they gave her busulfan and the fludarabine as consolidation, and you can see that there are different regimens for the myeloprotective regimens for before bone marrow transplantation. In her case, she took the busulfan, and both of them, whether fludarabine has heart failure cardiovascular toxicity, and as well as busulfan, one of its complications is cardiomyopathy too. And usually post stem cell transplantation, whether acute within the less than 100 days or more than 100 days, late complication, we have cardiovascular complication, and it includes heart failure, one of the complication, in addition to other cardiovascular and non-cardiovascular conditions. She presented on 30 November, as I told you, with acute heart failure de novo. But if we look back on this patient and risk stratified her according to the guidelines of 2022, she has no risk factors at the beginning, but I will tell you later on that troponin and BMP were not given as baseline, were not taken as baseline, but we can consider her as a low risk factor. She was started on treatment, but even if she was started on therapy, we should follow her up at least with natriuretic peptides or troponin, especially with anthracycline. We usually take troponin because of the myocyte death, but this patient was not followed up adequately. And as you can see here, echo was done before starting induction therapy, but there was no troponin, no anti-proBNP, and even no EKG at the beginning. With time, there was another echocardiography that was performed with a drop in GLS to 13.9, which is more than 15% in her case, and nothing was given for her as preventive therapy. Then she went to India, had bone marrow transplant, and actually they reported their mild LV dysfunction, started on beta blocker. They stopped beta blocker after a while, and then she came back to UE, where she presented with de novo acute heart failure, where she was sinus tachycardia, EF of 30%, elevated troponin, and anti-proBNP. Knowing that a persistent troponin in these patients, with follow-up in patients taking anthracycline chemotherapy, if it's persistent troponin, then they drop their EF. If we treat these patients with ACE inhibitors, and in other studies with ACE inhibitors and beta blocker, we reduce this drop in ejection fraction in these patients. And we should not rely on ejection fraction when we want to monitor these patients, because a drop in ejection fraction means that the toxicity has already been there, and we should try to look for other subclinical like GLS and biomarkers that will help us in reducing and determining early asymptomatic cardiotoxicity, because if we treat these patients early on, the chance of full recovery is higher in these patients. So back to this definition that already I have told you about, and usually in patients with no cardiotoxicity, we have only to follow up these patients, especially in anthracycline, and follow up the risk factors. But if they have symptomatic heart failure, we have to stop the medication and treat the patient with guideline-directed medical therapy as heart failure guidelines. But in these subclinical cardiotoxicity during cancer therapy, we should initiate preventive therapy with beta blocker ACE inhibitors with close follow-up, biomarkers, and echocardiography, so that we will be able to continue the treatment without interruption and improve patient cancer outcome. Similar case, which is case 2, but in this case, we have this patient has multiple comorbidities that put the patient at a higher risk, and she was diagnosed with Hodgkin lymphoma. She was treated with ABVD protocol, which is including bleomycin and anthracycline, doxorubicin. So this is the protocol. And actually, if we go with risk stratification, is at a high risk. This patient should be seen by cardiologists. You should be started on treatment with close follow-up. But actually, this patient was not followed up adequately, and they presented with acute de novo heart failure. This is why it's important to increase awareness among not only cardiologists, but among oncologists and hematologists to start screening early on and refer the patients early on. So this patient was not done echo at no echo was performed at the diagnosis, but Muga scan, which doesn't tell us about GLS and subclinical or any structural heart disease. That just told us about the ejection fraction. She continued the treatment. She developed COVID. There was a positive troponin that I don't know from where it's related, if to chemotherapy or the COVID. Nothing was done. She received 270 milligram per meter square, a high dose, and no adequate follow-up. Then she presented with this acute heart failure decompensation, as you can see here, and LOEF, congested, and tachycardic with the frequent VPBs in this condition. So in this patient, there was no appropriate risk stratification, no appropriate cardiotoxic monitoring, no appropriate imaging. There was no threshold for suspicion of cardiotoxicity, and there was no oncocardiology interaction. And actually, if it was started on preventable therapy, maybe we have reduced the risk of acute heart failure in these patients. So always we have to keep monitoring. Since the patient is at high risk, then she needs to follow up with each cycle with treatment with troponin, and every other cycle with an echocardiography to determine cardiotoxicity and treat the patients early on. So physician responsibility, whether cardiologist or oncologist, to know about the cardiovascular side effects if they see these patients, identify patients at risk with early referral, determine risk factors, preventive measures should be taken by them, and always we should have low threshold of complications and diagnosis. Always we need to monitor these patients during cancer therapy, but not only during, but if they have late cardiotoxicity like radiation and anthracycline based, we should have long-term follow-up up to 10 years in these patients, because they are still at risk to develop heart failure, especially in the moderate and high risk group. So for a cardiologist among you, the three main tasks when you see or encounter these cancer patients, first of all, we have to prevent heart failure by adequate risk stratification, early detection, and continuous monitoring. If the patient develops LV dysfunction, we should start treatment early on and diagnose early on to prevent complications. And if they have heart failure and develop symptomatic heart failure, we need to treat these patients during to prevent exacerbation of existing heart failure. So the triad is prevent, manage, monitor, and treat. I would like to thank you, and I am ready for questions at the end of the talks or session.
Thank you so much, Dr. Hadi. Amazing lecture. Our second speaker, Dr. Yusuf Hadi Darrat. He's the medical director of cardiac electrophysiology in St. Joseph Hospital, Lexington, Kentucky, USA. Assistant professor in University of Kentucky, ambassador of Libya in the African heart rhythm. He will give us a case of CRT non-responder. Dr. Yusuf.
First of all, I would like to thank the fourth Pan-Arab Heart Failure Conference for the opportunity to present. My talk will be a CRT non-responder, a case of CRT non-responder. So CRT by V pacing, just a quick introduction. So as you all know, the indications for CRT is left bundle branch block or non-left bundle, EF less than 35% with heart failure symptoms, no reversible etiology. It's been shown to reduce morbidity and mortality through multiple clinical trials. However, the problem we sometimes face is that about 30% of patients can be non-responders. And the non-response to CRT is usually multifactorial, or there could be more than one reason for CRT non-response. I will present the case and then I'll come back to it, but this is a 73-year-old male with non-ischemic cardiomyopathy or HFrEF, heart failure reduced ejection fraction, EF 25%. He actually had a BIV implant several years ago. I inherited him from my previous partner. And as you can see here from an EP standpoint, from an electrophysiologist, there's right bundle branch morphology, negative in lead 1, superior axis. So this is a good BIV morphology pacing. So I'm kind of happy looking at this, seeing that there's probably a good lead position. However, the patient didn't improve. There was actually his NYHA is class 2. It's been always the same. His EF remained about the same, 25%. So there must be something going on. How can I improve this patient's ejection fraction, maybe a functional class? So first of all is I'm going to dissect this lecture into 3 main parts. So how to achieve a response. So first of all, if we look at it before implant, appropriate patient selection is very important. That's step 1. During implant, appropriate lead position, very, very important. And then after implant, following the patient, maintenance, making sure that there's optimal pacing, and identify reasons for suboptimal pacing. And how to assess response, you can either do it by functional status, or it's whether it's a questionnaire, stress test, or a cardiopulmonary stress test, looking at how many heart failure hospitalizations during the past year, and then also remodeling whether his ejection fraction improved, what is the LV end systolic index also, can also determine response. So before implant, so companion trial is one of the landmark trials on CRT, and it included 1,500 patients, EF less than 35%, QRS more than 120, and it did show that there's definitely a significant improvement in mortality, reduction mortality, and heart failure death, and also hospitalization with CRT, especially with ICD implants. And this is an analysis from the trial. It does show that, and I've indicated the arrows, you can see the best response is actually in patients with left bundle branch block, more than 168 milliseconds. Okay, so the wider the QRS complex is, the better is the expected response to CRT. EF less than 20%, NYHA class 4. Also, it's known that females and non-ischemic cardiomyopathy should be the patients who will most likely respond. If you look at non-left bundles, actually, data is not really that supportive of that. Also, MERIT CRT, a bigger trial, I think it included 1,800 patients. Also did show, I'll show you the sub-analysis. You can see here in that dark blue left bundle branch block patients, they actually had better response to CRT. With regards to heart failure, you can see it's actually black, I'm sorry, it's the color black. You can see less heart failure, less heart failure death, VT, VF death, or VF death. So definitely left bundle branch block are the patients who do much better compared to non-left bundle, right bundle, or interventricular conduction delay. So that kind of highlights the importance of patient selection. The highest responders that we mentioned, this kind of summarizes it all. Wide QRS, left bundle, females on ischemic cardiomyopathy are expected to be the highest responders. On the other hand, narrow QRS, well, definitely, or most likely won't respond to CRT because there's no desynchrony, essentially, with narrow QRS. So what I did with this patient is actually I turned off BIV pacing, and I got a 12 lead EKG. And I recommend it if you see the patient for the first time, see what's the underlying QRS. He actually has the right bundle, so, and that's why he didn't respond. So what I decided to do, he was getting ready for a gen change, so I told his daughter that, okay, let's turn BIV pacing off. I'm going to follow him for the next 3 to 6 months, see how he does. Patient was on optimal guideline-directed medical therapy, definitely advocated by our partners and colleagues in heart failure on the 4 quadruple therapy. And he actually did well. No CHF hospitalization, no worsening of his EF, or no worsening of his functional status. I still actually see this patient till today for actually 2 years. This was 2 years ago. And he's still doing fine. No heart failure hospitalization, doing well. So I would save some battery. I can, rather than doing a battery change every 6-8 years, I can increase it to more than that, definitely, with only atrial pacing and no RV pacing at all, okay? So this is one of the reasons for CRT non-responders. I always recommend looking at the underlying bundle branch morphology. This is an excellent example of CRT response. So on the other end, this is someone who's 75 years old, female, ischemic cardiomyopathy, NYHA class 2 EF 20%. She had severe MR. I think Dr. Mohsen earlier talked about severe MR, and those patients, if their ejection fraction improve or there's positive remodeling, their MR might improve because it's secondary MR. This happened in this patient too, but with bivalve pacing. You can see the morphology of bivalve pacing. Her EF improved from 20% to 44%. She had a true left bundle branch block at baseline, and that's why this patient responded. So in contrast, this is a good patient who would expect to respond. So first of all, the first thing to do is to select the right patient. Left bundle branch block, QRS more than 150, that's what I would recommend. So during implant, and this is the role of the electrophysiologist, is to make sure that or the interventional implanter, some of our interventional colleagues implant BIVs. So basal and lateral position is the best. That's what's recommended. Because this is the kind of the latest side of activation. So in left bundle branch block, what would be activated last? We expect it's going to be the most lateral wall, the basal part of the LV. So that's where we're going to put our LV lead, so we can pace from that location in order to synchronize with the RV lead. This is an example. One of my cases, and you can see this branch in the middle, that lateral branch. This is a nice, if I look at this, this is beautiful. This is a nice, juicy branch. I'll put it there. Hopefully there's no diaphragmatic stimulation. And the patient should do well if it's a left bundle branch block patient. Okay. So before I leave the lab, I want to make sure that there's a negative in lead 1. I usually look at lead 1, the first thing. Make sure that it's negative, a QR in lead 1, even a QS would be fine. And then a right bundle branch morphology V1. So those are the 2 main things you want to look before you leave the EP lab or before you leave the CAT lab to make sure that this patient has a good lead position. So after implant, so this is the challenging part. So you've done your due diligence, you've implanted a BIV left bundle branch block and a good lead position. So why is the patient not improving? So based on this analysis, there's the most common reason for suboptimal response is AV timing, okay? So we'll talk about AV timing. The other reason is arrhythmias. So we do encounter arrhythmias, and whether it's AFib or PVCs, they can interfere with BIV pacing and result in suboptimal pacing. There are other reasons like anemia, suboptimal LV lead position, which you should have done your work in avoiding that. So we'll talk about, next we'll talk about the arrhythmias. So this is AFib. So there's definitely better response in BIV pacing with patients who have no AFib, and BIV pacing is more than 98%. The more we pace, the better. The cutoff for pacing, there's different opinions, if you do a literature review, you'll see different numbers, data, at least 91%, definitely better with 98.5% or 98%. This patient, for example, if you compare no AFib, but 98.5%, they had the lesser, this is the survival. So the axis, the y-axis and the x-axis, the survival is less in patients actually, is the least in patients with BIV pacing, less than 98 and AFib. So we know that AFib interferes with BIV pacing. Even if you notice that your BIV pacing is like 95 or 92%, there could be fusion because AFib is irregular. So you can have some fused beat and not really optimal pacing. So it's always important to get rid of AFib. I'm going to give you an example. This is a 77-year-old patient of mine that I've seen for many years. He had left bundle branch block, EF 40% for years, and he did well. Then all of a sudden his EF dropped. He developed AFib. And so I decided to medically manage him. I put him on quadruple therapy. We watched him for 3 months, maybe a little bit over 3 months. And then I wanted to do rhythm control. I wanted to actually cardiovert him. We cardiovert him, put him on amiodarone, but the AFib came back. So I decided to do a PVI, pulmonary vein isolation, but the patient kept worsening, and he was readmitted with heart failure, didn't tolerate maximum guideline-directed medical therapy, borderline blood pressure. So I decided to do something. So I decided to proceed with BIV. So as you can see here in the previous, he has left bundle branch block, about 150-ish, 150 milliseconds. And so with BIV pacing, here's BIV pacing. But as you can notice here that, so if you look up there, lead 1 negative, so QS, this is beautiful, this is a good lead position. And if you look at V1, there's the first complex is narrow, but then it gets wider, there's some fusion. So he's getting suboptimal BIV pacing. Okay, so that's one of the reasons for non-response. If you look at here, his BIV pacing percentage was 76%. There, the second line. AFib burden 100%. So I decided to do an AV nodal ablation, ablate him pace, and I said he's 77, dilated left atrium, though for me, I always try rhythm control first. I always try to do a PVI if I can, but in this case, he has a lot of debility, multiple hospitalization. Decided just let's get to the point of AV nodal ablation. And he actually did much better. He's doing really well. And as you can see here, after AV nodal ablation, BIV pacing went up to 99%. So he's doing very well. So just to kind of go over workup for non-responders. So first of all, definitely, and I'm sure my heart failure colleagues will agree, verify guideline-directed medical therapy, the quadruple therapy. ECG without BIV pacing to look at whether the patient has left bundle branch block or not, and also to try to optimize AV delay. Look for anemia, metabolic derangements, get a Holter, look for AFib, PVCs, PVC burden. Sometimes you can't really get a good PVC burden on a device. Chest X-ray, PL lateral for good lead position. We want like to lateral position or posterior lateral. Echo for AV delay could be used, but you can just empiric AV delay is also good enough. Consider ischemic evaluation or valve disorder like severe mitral regurgitation despite treating patient with BIV, but if they still have primary severe MR, they may need surgery for that. So echo optimization has been shown ineffective compared to empiric programming. So if you program the AV delay to 100 to 120, that should be good enough. Also, multiple companies came out with different algorithms for AV optimization. It also came out as it's not really that effective, not very helpful, no difference in outcomes. There's also multi-point pacing was something like maybe 10 years ago, and there was a lot of talk about it that it could be helpful. Not very helpful, not out there anymore, but it could be helpful in certain patients who are non-responders that could be considered. It's an Abbott device. Adapt response trial did not demonstrate difference in 5-year outcome of all-cause death or heart failure with adaptive versus conventional CRT. So the other thing that I want to mention real quick, so if you have a non-responder and you've done everything, left bundle branch area is an interesting field that's getting a lot of traction nowadays and for the last few years in EP. I think in the future there's going to be more left bundle branch area pacing. I personally, if I implant a BIV or an LV lead, I cannot get a good position or cannot engage the CS or there's diaphragmatic stimulation, I would put a left bundle, and surprisingly, I mean, it could be definitely, in some cases, much better than BIV pacing. I would be surprised, like, oh, the QRS looks narrow, it's perfect, it's a good physiological pacing. There's retrospective data, observational, no randomized trial, but there's some randomized trials going on, so hopefully we look forward for the results of the randomized trials. Cardiac contractility modulator, available in the US, I'm not sure if it's available in Europe. I've done some cases, it's helpful in those patients who have a non-left bundle or have left bundle branch block, had CRT, and non-responders. It helps with functional CAS, it does improve symptoms. I've noticed that it does improve symptoms. The EF, not sure, maybe there's some data out there or maybe there's some randomized trials coming, but I did really see an improvement in functional class. So take home message, very important, appropriate patient selection. left bundle branch block more than 150. The guidelines still say as a class 2, non-left bundle more than 150 with multiple hospitalization, heart failure. It's reasonable, it can be done. But if you don't see a response, then you know what the reason is. But left bundle branch block is more than 150 is the most important criteria for patient selection. Place the lead in a lateral position. Look for reason for suboptimal response. We talked about those. And conduction system pacing, hopefully a promising therapy in the future. Thank you all.
Thank you so much, Dr. Youssef. Now we will invite Dr. Emil Najjar for his second presentation, and he will give us a challenging case of myocarditis.
Hi again. I'm really impressed that you are still struggling to the last session. So let's talk about myocarditis. These are my financial disclosures. And this is one of our cases and that I will present now. And the case was presented as was published as a case report for 1 year ago. And this is a case of giant cell myocarditis. So this is a 23-year-old young woman with many autoimmune diseases, including ulcerative colitis, autoimmune pancreatitis, and psoriasis. She presented to the hospital, to the emergency, with chest pain and difficulty in breathing. And initially she was stable. The blood pressure was okay, 114 through 81. The heart-lung examination was normal. They took an ECG in the emergency, and you can see in V1, V2, and V3 probably ST elevation. So what do you think we should do? What is the next step? A young patient, autoimmune diseases, chest pain, ECG showing ST elevation. Acute coronary syndrome. So should we do angio? She is only 23. What do you think? And since this is Karolinska, Sweden, we can do everything. So they took initially the troponin. This is the high sensitive troponin. Is it used in Libya? High sensitive troponin? What? Okay, so this is high sensitive troponin, which reflects cardiac myocyte damage. So high troponin levels, NT-proBNP was really high, 15,400. They started by doing CT pulmonary angio, no pulmonary embolism. They did echo in the emergency, and they saw biventricular failure, but the left ventricular was not dilated. So this is something acute. Biventricular failure and akinesia in the apical segments. So they started to think about Takotsubo. So chest pain, ST elevation, biventricular failure, no dilatation, probably maybe Takotsubo. So they went further to coronary angiography, and that was normal. So the patient was admitted. I met the patient on day 2. Here I met the patient in the ICU, in the usual ICU. We have 2 different ICUs, the usual ICU and the thoracic ICU. This is the first one. She was admitted to the hospital, and they moved the patient to the ICU because of hypotension with hypoperfusion. Hypoperfusion, little bit confusion, cold extremities, the urine production was less, so they moved the patient to the ICU. In the ICU, they started vasopressor support to increase the blood pressure, and then they started to add different medications. So you are adding noradrenaline to improve the blood pressure, but the noradrenaline will cause increase the systemic vascular resistance, so the failing heart will start to struggle. So that's why we added inotropic agent, 2 different inotropic agents. So now you have a patient with cardiogenic shock, hypoperfusion, and hypotension. You are using noradrenaline as vasopressor. You are using 2 different inotropic agents. And I met her on day 2 in the ICU, moved the patient to the thoracic ICU. Ideally, you should do cardiac MRI if you want to have the ideal scenario, but she had claustrophobia, so we went to biopsy, and the biopsy showed severe myocarditis with giant cell. This is a special type of myocarditis which is really fatal. So we started the immunosuppressive therapy, and we started from the beginning thinking of plan B, which was transplantation. Few patients each year in Sweden, about 10 to 15 cases. We have a population of 10 million. 10 to 15 patients develop severe myocarditis that go to urgent call transplantation. So we started the immunosuppressive therapy, and then we started the transplantation workup. And this is her biopsy, too much inflammation with giant cell infiltration. And then she, despite therapies with vasopressors, with inotropic agents, she deteriorated. So we started the VA ECMO. The problem with VA ECMO that it increases the systemic vascular resistance because the flow will go back to the heart. So it doesn't unload the left ventricle. We adjusted the immunosuppressive therapy, and we continued with immunosuppressive therapy with ECMO for 16 days, almost 2 weeks, and then we were able to do cardiac MRI on day 28, which showed that the septum was only 2 millimeters in thickness, almost no muscle in the septum. These are the cardiac MRI images. Day 29 to 55, she was stable. We gave her an ICD. She was discharged 2 months later. And then after discharge, we usually use levosimendan. Levosimendan is a calcium sensitizer. It's an inotropic agent that is not used in the US, only in Europe. And the good thing about levosimendan that the clinical effect to stabilize patient is usually between 7 to 9 days. So we use levosimendan to stabilize the patient in the outpatient unit, but she continued to have hypotension. We reduced her heart failure medications. We continued the transplantation, the pre-transplant workup, and she was accepted for transplantation in the normal priority list. But then, 6 months after discharge, while waiting for the transplantation, she was admitted because of severe deterioration, ICU again, and we did heart catheterization. It showed that the patient had only 1.9 in cardiac index, very low cardiac output, and the echo showed biventricular failure despite steroids and immunosuppressive therapy. So at that time, we decided to go for the LVAD as a bridge to transplantation. But the question was, will her right ventricular function survive the post-LVAD period? What about the immunosuppressive therapy? We decided to stop some of the immunosuppressive treatment due to poor kidney function. She received the LVAD. The right ventricular function did well with some adjustment of pump speed and with the help of inotropic agents, but then 2 months after LVAD implantation, the patient developed ventricular arrhythmias. The problem with ventricular arrhythmias in the post-LVAD period, these patients can come to the emergency with ongoing ventricular arrhythmias. No problem, the pump will survive. But the problem was the right ventricle. When you develop ventricular arrhythmias, the right ventricle may develop severe failure because of the arrhythmias, and that was happened with the patient. So we decided to add ECMO, and then we went to urgent transplantation, and we went to urgent transplantation. They took biopsy from the transplanted heart, and there was again severe giant cell myocarditis. So despite LVAD, despite the immunosuppressive therapy, the patient had severe giant cell myocarditis. After transplantation, she got again giant cell myocarditis in the new heart, plus rejection. But now she's doing well 4 years after transplantation. Her ejection fraction is 50%, but she's suffering from kidney failure with the eGFR of about 35%, but she's doing well. So I have only 5 slides to discuss. Here are the guidelines, the European guidelines, how to manage patients with myocarditis and pericarditis. I encourage you to read more about myocarditis and pericarditis. You will see the evidence. And in these guidelines, they tell us that now we have a new term, inflammatory myocardial syndrome, myopericardial syndrome, which includes myocarditis, pericarditis, myopericarditis, or yes. So there are 4 different diagnoses under the inflammatory myopericardial syndrome. And if you look at the algorithm, you see that biopsy and cardiac MRI are really important to get the diagnosis. And some of the common causes of myocarditis are viral infections, like common cold viral infections. Some of them are autoimmune or inflammatory, like the giant cell rheumatic diseases, and some of them are related to cancer therapies. So there are different types of myocarditis, and we need to understand that some of the patients, they have acute myocarditis, some of them may develop chronic myocarditis, and chronic myocarditis with symptoms more than 3 months, and you have to understand that viral infection, for example, they may lead to direct damage, or they may lead to initiation of immunological response leading to myocarditis. So to those who responded that we should do angiography, yes, these are the guidelines. Even if the patient is young, you have to exclude coronary disease. And we have, here are the, how can we define, how can we be sure that the patient has myocarditis? We need biopsy or cardiac MRI. Giant cell myocarditis is really rare, but it's fatal. They usually present with cardiogenic shock or arrhythmias, and sometimes the diagnosis is difficult, and the treatment is really challenging. And my take-home messages to you, look at these guidelines. There is unified umbrella concept, inflammatory myopericardial syndrome. Cardiac imaging is important to get the diagnosis together with the biopsy. And the biopsy will help you to see the progress. And you need to exclude ischemic heart diseases. And there are different etiologies of myocarditis. And thank you.
Thank you very much for this very nice presentation. And we move to the last presentation, a case of hypertrophic cardiomyopathy, which will be presented by Dr. Ramzi Tabalat from Jordan.
Thank you so much. بنلطف الجو شوي، كلها حالات صعبة. بدنا نحكي على a case of a patient with hypertrophic cardiomyopathy. So this is a 29-year-old male. He's Jordanian. Complained of shortness of breath when he was at the age of 15, so about 14 years before, to the point where he was unable to participate in sports when he was in school. At age 20, 5 years after his initial presentation, he was told of left ventricular hypertrophy. He saw a cardiologist. He was diagnosed with having left ventricular hypertrophy, and the measured thickness of the LV walls were 40 millimeters. He was started on beta blockers, was intolerant, so he stopped the drug after a few months. In October of 23, he was admitted because he needed nasal sinus surgery, and while he was in surgery, he was noted to have an abnormal heart rhythm, which was diagnosed as a non-sustained ventricular tachycardia. So an electrophysiologist was consulted, CMR was done, and he was connected to a one-week Holter. So the CMR showed asymmetric concentric, mainly septal pattern of LVH. I'm just reading the report. This is even before we saw him for the first time in our clinic. And the thickness reported in the CMR report was 25 millimeters. So he had severely thickened left ventricular walls. He had positive systolic anterior motion of the mitral valve with mild mitral regurgitation. There was a small faint patchy intramyocardial fibrosis and enhancement. No evidence of LVOT or mid-ventricular obstruction with maximum LVOT velocity of about 2 meters per second, translating to a gradient of about 16. And he had good biventricular functions. The Holter showed a heart rate of 98, maximum heart rate was 138, minimum heart rate was 58. He had 3 ventricular ectopic beats, all were singles, no supraventricular ectopic, so it was a benign Holter. Because of the left ventricular hypertrophy that could not be explained by other pathologies or loading conditions, he was diagnosed with hypertrophic cardiomyopathy, non-obstructive, because the gradient on both the echocardiogram and also the MRI did not show an increase in the LVOT gradients. And he had an ICD at the same time. So when we saw him, we wanted to question whether he was really a candidate for an ICD. Was the decision to put an ICD was a proper one or not a proper one? And we do this by doing risk calculations. So there is a calculator embedded in the American guidelines on hypertrophic cardiomyopathy, and there's also one which is very similar to the American calculator embedded in the European Society of Cardiology guidelines. Both, they help you to estimate the 5-year risk of sudden death. And this is very, very important in patients with hypertrophic cardiomyopathy, because one of the ways they die is by sudden cardiac death. And the stories about athletes dying in the field while playing in a game, a lot of these patients die because of undiagnosed, unrecognized hypertrophic cardiomyopathy. So with the calculator, what we do is we enter some of the clinical features that the patients have, and also features that we detect on the echocardiogram, and you get 2 different numbers, or you get a number or an estimate of the 5-year risk for sudden cardiac death. So if the risk is less than 4%, this is usually low risk, and in these cases, an ICD is not indicated, unless there are other risk factors that are present in the patient, which might convince you or may make you more in favor of putting an ICD. But generally, if the 5-year risk for sudden cardiac death is less than 4%, an ICD is not indicated, so it's a class 2B indication. Now, if the risk is 6% or more, the patient will need a pacemaker, an ICD. So that's a strong indication to put an ICD in these patients, and it's a class 2A indication. If the 5-year risk is between 4 and less than 6%, then this is an intermediate risk. An ICD may be implanted, but this also requires a discussion with the family and with the patient himself or herself. Now remember, all of this is done when there is no history of sustained ventricular tachycardia and when there is no history of sudden cardiac death in a patient. If the patient has any of these two, then it becomes a secondary prevention indication, and this is a class 1 indication to put an ICD. So looking at this and doing the calculation, his age, the maximum LV wall thickness, left atrial size, the LVOT gradient, and the family history of sudden cardiac death, whether absent or present, non-sustained VT, yes or no, unexplained syncope, yes or no. His 5-year risk for sudden cardiac death was 7%. So he was clearly a candidate for an ICD, and the ICD, the decision to put an ICD in this patient was appropriate. We saw him for the first time on April 2025. He was still complaining of dyspnea, so he was still symptomatic. He had an ICD, but he was still symptomatic. No history of syncope. His past medical history was significant for gout. He was a smoker, and he was also a high caffeine consumer. His family history, he had 2 brothers and 2 sisters, all were healthy. There was no family history of sudden cardiac death, no history of hypertrophic cardiomyopathy. When we saw him, he was on a low-dose bisoprolol, a beta blocker, and he was also on colchicine for his gout. His blood pressure was 137/75. And this is his ECG. He was in sinus rhythm, non-paced rhythm, and the QRS showed left ventricular hypertrophy with strain, and there's some intraventricular conduction delay pattern. So as we always do, we did an echocardiogram, and if I can play these. So this is, if you look at the echocardiogram, you can appreciate the presence of the basal septal hypertrophy. It is thickened. And if you also focus on the mitral valve, you can see the systolic anterior motion of the mitral valve. And it's almost touching the LVOT, the septum. So it's in systole, the anterior mitral valve leaflet moves into the LVOT tract, obstructing the LVO tract. But again, he was worked up, and he was decided not to be an obstructive hypertrophic cardiomyopathy, but rather a non-obstructive hypertrophic cardiomyopathy because of a gradient of 17 on assessment. Again, you can see the same thing. If you focus on the septum, you can see the thickening. If you look at the mitral valve leaflets, you can see the systolic anterior motion of the leaflets butting against the septum and causing some obstruction in the LVOT tract. We did a Doppler, and again, the Doppler, probably the numbers were the same. He had a velocity of less than 2 meters per second, which indicated that the LVOT gradient was less than 16. It was about 12. So what we do in these cases, when we do an echo, resting echo, we don't stop there. We usually do some maneuvers in order to provoke an LVOT obstruction, and the most common maneuver that is done is the Valsalva maneuver. So you ask the patient to hold their breath and push against resistance. You can do that by different ways. But you have to remember, it has to be a very good quality Valsalva maneuver, not any Valsalva maneuver, because patients vary in their understanding of what they need to do when you do the Valsalva. So you have to make sure that they do a good Valsalva. And remember, when you are assessing a gradient, you assess it during the phase of straining, not after the patient releases the strain, which is the case when you assess right to left shunts in patients with ASDs or PFOs. Here you need to assess the impact of a Valsalva on the LVOT gradient while the patient is straining. So you ask the patient to strain, and you do a Valsalva, and you do an assessment of the LVOT Doppler. And it did not change. It was 12 before Valsalva, and when Valsalva was done, it was only 17. Here you can see the mild mitral regurgitation, and it was a central jet. On top of that, you can see the M mode, and you can see the systolic anterior motion of the mitral valve. You know, the valve is open in diastole. In systole, it's supposed to be a flat line, now you can see that something is going up and making like a hump. And that's the anterior mitral valve leaflet going against the septum. So what is the diagnosis here? Are we done? Is that enough, or we need to do more? So the thing that needs to be done in all patients, remember, when we do these, we're trying to separate between non-obstructive hypertrophic cardiomyopathy and obstructive hypertrophic cardiomyopathy, because that designation, that distinction is extremely important when it comes to management. They're totally different diseases, and they're managed differently. In non-obstructive hypertrophic cardiomyopathy, the management is mainly medical, with very few drugs, beta blockers, calcium channel blockers. You can use anti-failure medications. And in patients who get LV systolic dysfunction, heart transplant. In obstructive hypertrophic cardiomyopathy, the treatment plan is totally different, and I will explain that. And the cutoff to separate non-obstructive against obstructive hypertrophic cardiomyopathy is 50 millimeters of mercury. So this is what you try to see if the patient with anything, at rest or with any maneuver, develop a gradient of 50 or more. So with the Valsalva, that didn't happen. It was 17. So what you do, the next step, and it should be done in all patients who do not get a gradient of over 50 at rest or with the Valsalva, you can also do other maneuvers like squatting or stand and squat, stand and squat. These also work like a Valsalva maneuver. You have to do a stress test. It's a must. It has to be done in all patients in whom you do not provoke a gradient of 50 or more. I'm saying that, I'm stressing that point because this is what's been happening to most of hypertrophic cardiomyopathy patients that we've seen over the past 2 months, is that the physicians do the workup, but they never do that step. And it's actually recommended that you do the stress test while the patient is postprandial. That increases the sensitivity of the stress test to be positive. So you send the patient down to the cafeteria, you ask the patient to go have a meal, patient comes back and you do a stress test. And it's stress echo, so you'll have to have an echo machine next to the stress test. You do the stress test, it's a maximal stress test or maximally tolerated stress test, and immediately you move the patient from the treadmill to the bed, they lean on their left side, and you do a Doppler assessment of the LVOT. So it has to be done while the heart rate is still high. You cannot just take the patient to the other room where the echo is, waste 2, 3, or 4 minutes, because by that time the heart rate would have dropped, and what you try to achieve is gone. The opportunity to detect a gradient during stress disappears. So this patient, we took him to we brought him back and we did a stress test. He was able to achieve 74% of the maximum heart rate, complained of chest pain, and this didn't have to go fast because it's running out of time. And his LVOT gradient with stress was 74. So now we've changed the whole diagnosis. Now he's not non-obstructive anymore. He's a patient with obstructive, and that is the reason why this patient was symptomatic all the time. Because of the complaint of chest pain, we did a coronary CT, and his coronaries were absolutely normal. This is just a sign of his LV. You can see the thickness of the septum, and you can also see the systolic anterior motion of the mitral valve. So the treatment options now are different. There are 3 options for how to treat patients with obstructive hypertrophic cardiomyopathy. If you bypass the stage where you give beta blockers or calcium channel blocker or disopyramide when it is available, you move into cardiomyosin inhibitors, mavacamten and aficamten. Mavacamten is now available. Aficamten will soon be approved for use in these patients. Or you move to septal reduction therapies, which can be surgical myectomy or can be alcohol septal ablation. The choice between these therapies requires, assessing the patient's conditions, talking to the patients and their families, and also the expertise that you have available in your center. So we have a center of excellence in where I work in the Abdali Hospital in Amman. So we usually discuss these cases in a multidisciplinary team that involves cardiologists, surgeons, and other subspecialties. And we've decided, this patient will go for a surgical myectomy, which he will have, I think, next week. So I'm just 2 slides that just to inform you that we have now a Center of Excellence for Hypertrophic Cardiomyopathy, and I encourage you, who in Libya, someone has to take that initiative, to start thinking about having a Center of Excellence for this disease, because without this, a lot of these patients will go undiagnosed, where the workup is incomplete, and unfortunately, a lot of these patients continue to complain without really having a correct diagnosis. We've seen that not in this patient, but in a few other patients. There was even a patient that I saw that for 2 years in the USA, he was being seen by physicians, and he was never diagnosed appropriately. He came to my office because he was visiting Jordan, and I saw him, and I just did what I did, and voila, we knew. We diagnosed him with hypertrophic cardiomyopathy obstructive. He went back to the US, now he's having an ICD, and they're going to also treat him either with septal reduction therapy or with myosin inhibitors. So we have some activities in the center. We have 2 lectures, Zoom lectures, talking about alcohol septal ablation and also talking about surgical myectomies. And we have a Zoom lecture coming on the 19th of November talking about sudden cardiac death in athletes, focusing on hypertrophic cardiomyopathy as a cause, and also focusing on the pre-participation screening, which is important in athletes. You're welcome to join. You can attend this lecture. If you scan the QR code, it will take you to the registration site, and you can register and attend this activity. With that, I end. Thank you so much.
Thank you, Dr. Ramzi, for the excellent presentation. Dr. Hadi with us? Dr. Hadi? Dr. Hadi was...
I am with you. I am with you.
He's unwell and he waited patiently for 2 sessions. Tahur, inshallah, Dr. Hadi. And we start with Dr. Hadi. If you have any question to the cardio-oncology case. Anyone from oncology or interest in cardio-oncology? I have a question, Dr. Hadi, about anthracycline, your case of anthracycline. Do we have option of, we inherited that anthracycline usually is a reversible damage. Do you have any option of interruption and going back to give a patient anthracycline?
You mean, Dr. Salah, be challenging him with anthracycline? The patient developed cardiotoxicity on anthracycline, and to re-challenge him later on with anthracycline, you mean?
Yes, exactly.
Yeah. So usually any drop to more than 40 with an AF more than 40%, if we can stop anthracycline, optimize medical therapy, and we can resume it with close observation, knowing that the patient is high risk, especially if the patient this is the only treatment that the patient can have. And in addition to that, we can have liposomal anthracycline that can be given, and we can have the iron chelators, doxorubicin, also to be given in these patients, in addition to optimal medical therapy. I have a patient whose EF was ischemic cardiomyopathy with an EF of 35% to be initiated on anthracycline-based therapy because this is the only way of his lymphoma. And actually, I optimized his therapy before anthracycline, optimized the guideline-directed medical therapy, and was following him up very closely after each cycle, and after 2 cycles echo and troponin with each cycle, and BMP, and he completed the 6 doses with no complications, and his EF stayed stable. But actually, unfortunately, he died because of his disease itself with no deterioration in his heart. So, yes, you can.
Yeah, thank you so much, Dr.
Yeah,
Hadi. Thank you. So, yes, Dr. Abdu.
I have a question for Yusuf. You know, I know the data behind CRT and response to CRT and selection for CRT therapy. Anecdotally, I want your comment actually, and from your experience about the left ventricular size. You know, in anecdote, we've noticed that when we implant CRTs in very dilated left ventricles, they usually do not respond very well. However, if you look at all the trials, and even meta-analysis on these trials, that the left ventricular size was not an indicator to suggest responders versus non-responders. So I'm really curious about your experience in that May.
Thanks, Dr. Abdu. So the question is whether LV remodeling, positive remodeling, seen with CRT, and so whether, rephrase the question again, so it's, do not respond. I don't recall implanting a BIV in a 7 centimeter. That's pretty huge. But I've seen patients with, for example, tachycardia-induced cardiomyopathy. I was discussing with Dr. Mohsen Saleh here. He had a patient with cardiogenic shock who came in with AFib with RVR and severely dilated left atrium. I don't know what the atrial size, the left ventricular size is. But I've seen positive remodeling, even in the atrium. 7 centimeters is pretty big. The question is, what's the underlying etiology? So if it's a burnout left ventricle, probably it will not respond. That's my thought on this. Yeah, and you guys are the experts on this. I implant the device and send it back to you. So
A question for Dr. Yusuf. Excuse me.
Yes.
If the bad response or no response is related to a poor position of target vein, for example, in apical position, what should you propose? CSP, for example, or LOT CRT, that means CSP and pacing in coronary sinus lead, or surgical solution by mini-invasive approach, for example?
Yeah, a great question, Dr. Yusuf bin Amr. My practice, and I think majority of electrophysiologists, that nowadays with the availability of physiological pacing, which conduction system pacing, left bundle branch area pacing, if we cannot put the lead in a good location, like you said, end up in a location that's not optimal, there's diaphragmatic stimulation, issues with the lead, I tend to use conduction system pacing, which is left bundle branch area pacing. I used, before I started using left bundle branch area pacing, I used to send the patient to a surgeon for epicardial leads. But that's essentially in the last 3 years, I have not sent a single patient to a surgeon for an epicardial lead. I use conduction system pacing. So I think it's, and I know that in Tunisia you all do a lot of conduction system pacing. I think it's an excellent replacement for BIV. Hopefully the data would support what we think, because it's so far it's observational data that's showing a promising therapy. We'll see what the randomized trials show.
Yes, I agree with you. CSP will be a good solution for this patient. Another question from the audience? Or,
Yes. For Dr. Yusuf, it's a more clinical question. If you have somebody who's eligible for CRTP, ejection fraction of 30%, been medical therapy for some time, would you, because it's an expense issue I'm talking about, would you just try CRTP for a few months and then reassess if they still have impaired systolic function, eligible for ICD, then you upgrade? Or what is your intake on CRTD versus?
Yeah, so it's a patient with left bundle branch branch block and EF 30%. So the data already tells us, based on the randomized trials, I think MEDIT CRT did show that, or companion, they implanted CRTP versus BIV, and the BIV ICD did better. There's less risk of death. So I still would recommend, I know that expense is an issue. In availability, sometimes the problem if someone needs a device and you don't have any other option, risk versus benefit, I think that if that's the only option left, you would go for it. But definitely would advocate for a BIV ICD, because there's data to support BIV ICDs will definitely reduce mortality compared to just CRTP in this population. Not in like, for example, pacemaker-mediated cardiomyopathy, for example, someone has frequent RV pacing, pacemaker-mediated cardiomyopathy, F drops down to 30%, I would just put CRTP. I expect the F would improve.
That's what I'm saying.
Yeah, but for those patients with left bundle branch block, cardiomyopathy, ischemic or non-ischemic, CRT-D is the recommended therapy.
All right, great.
Yeah.
Another question?
Thank you.
Waiting for the other question, I would like to ask a question for Dr. Tabalat from Jordan about cardiomyopathy. What is the influence of an apical left aneurysm on the decision to implant ICD, because this factor is not taken into account in the ESC score?
The influence of what, sorry?
Apical aneurysm of
Okay,
LV.
so when I presented the slide on the two risk assessment scores, I said there are some differences, and these are the differences. The Americans also include some modifiers. One of them is if you have more than 15% of the left ventricular mass showing late gadolinium enhancement or fibrosis, that's one thing. Apical aneurysm is the second one, and the presence of an LV ejection fraction less than 50%. So these are three modifiers that are included in the American sudden cardiac death calculator, not included in the European Society of Cardiology calculation. So, and that's what I said, when you have a sudden cardiac death of between 4 and 6%, you might use these modifiers to make you more towards putting an ICD, or to defer that decision later. Remember, at ICD, hypertrophic cardiomyopathy, we also see it in children. So putting an ICD in a child is a big issue by itself. So it's not a benign thing. So that's why it's all, the decision to put an ICD in a lot of these patients has to involve discussion with the family, and maybe going with the less aggressive. And some families will decide against putting an ICD, although they know very well the risk associated with sudden cardiac death in their child.
A question for Dr. Emil Najjar about myocarditis.
Enjoyed your talk about the hypertrophic cardiomyopathy. I think I like his recommendation about developing a niche in Libya. I think this is I wouldn't say a very common case, but it is actually common, but it's probably underdiagnosed, very common cause of sudden death in younger and athletes. And I think the message is trying to develop a center of excellence where there is few people from cardiology, from surgeon to tackle it. And I think my recommendation or my advice is to have one center, probably a whole Libya, because a lot of these cases are elective. And I think the last thing you want to see is he does one, I do two, you do five, and none of us will become expert. So this is a niche thing that needs both. Whoever is going to do alcohol septal ablation versus surgical myectomy, it has to be probably limited to 1 or 2 operator per, I don't know, God knows, 5-10 million population.
If there is no other question, we thank all the audience and my friend Dr. Salah for this relevant session. Thank you for all, and for the next session.